Good afternoon. I'm Dr. James Morris. I'm one of the gastroenterologists here in the section of Gastroenterology and Hepatology, and I'm going to discuss today the topic of hepatitis C from an extrahepatic perspective. It is more than just the liver. So initially, let me begin with my disclosure statement that is now changed as of today, that we have to change based on the CME. I have no disclosures. That has to be given written and verbally at this point from now on in our CME exercises. So I will discuss drugs that are no longer MAG, that are no longer guideline recommended for the treatment of hepatitis C virus, and also drugs in the context of a historical perspective of hepatitis C virus and their extrahepatic manifestations. And I also will be discussing some brand names here for the simplification of many of these drugs are in combinations and it gets confusing to keep them all straight from the generic perspective. With that being said, let's begin first with what is the problem. Well, the problem is that hepatitis C has been with us for many years, but initially identified in 1989, that was 27 years ago. Prior to 1989, it was known as non-A, non-B hepatitis. It is estimated there are 3 to 5 million Americans who are infected currently with hepatitis C, but that value may be underrepresented because it does not include the patients who are incarcerated or those who are undocumented. If you're interested in a brief timeline of the history of hepatitis C, there's a nice short discourse on this website called hepatitiscentral.com that one can review. So if we look at a distribution of hepatitis C virus, you see that there is an area here that is very dark, and that's Louisiana and Mississippi. Of course, we've got problems with everything else. We might as well add hepatitis C to the mix. I would add that there are several states that have no dark coloring of the state, and that may represent, or that represents no data. So it's not completely a wash for us, but there is a high percentage of our population who has at least the possibility of having hepatitis C. And if we look at a timeline of hepatitis C, and I know this is a little small, but to try and fit it all in, I had to make this slide rather large. We see that in the 1970s, we had non-A, non-B hepatitis. We had the discovery of the virus in 1989, shown here. And shortly thereafter, we developed an interferon treatment for the treatment of hepatitis C. Unfortunately, the chance of cure, or what we termed at that time an SVR, sustained virological response, was very low, down in the low numbers of 2 to 4% at best. In 1992, we began to test the blood, and with the subsequent testing of blood, what we see is that individuals became identified with hepatitis C, and the potential for transmittance of hepatitis C in our blood supply was reduced significantly. If we move on in our timeline, in the late 90s, we began to see the introduction of pegylated interferon and ribavirin combinations, which were used for treatment of hepatitis C, upwards of a year or longer for treatment. And we see that the rate of sustained virological response in these patients only achieved about a 20 to 40% chance. In about 2001, we see that there was the introduction of 2 new drugs called protease inhibitors, represented by PI here on the slide. This was what you could say was the Boston Tea Party and revolution of the treatment of hepatitis C, as this triggered a substantial increase in the chance of achieving SVR. And since 2013, we've had the introduction of what are known as the directly acting antiviral agents, and our chance of achieving a sustained virological response or cure in these patients is now reaching upwards of 95 to 100% in patients. Most of these drugs are once a day treatments lasting anywhere from 8 to 12 weeks total. Side effect profile is really headache and fatigue. And that's really essentially the side effect profile of these agents. Before, we used to worry about cytopenias and suicidal depression and effects on the eyes and thyroid and so forth. Those effects essentially have been essentially removed. And finally, on Thursday, it looks like the FDA will approve another drug, which I've got listed here, which is a combination of graciprevir and elzbavir. The difference between that drug and the drugs that are currently released are the drugs that are released right now are specific to a genotype. Remember that hepatitis C comes in 6 ice cream flavors, I tell patients, of 1 through 6, with 1 being the most common, and that's where we have targeted treatment is for genotype 1. But I think on Thursday will be approval for a pan-genotypic drug, so it does not matter which genotype you are, and it is a once-a-day pill if it is approved by the FDA on Thursday. So let me just take a step and just introduce you to the concept of the way that these drugs work. So you see here in this rather complicated slide that the hepatitis C virus enters the cell through attachment and entry. It eventually makes a RNA strand, which then gets placed into a translation. And in the process of translation, that is where the protease inhibitors work in order to prevent replication of the virus. If you look further on in the replication complex, this is where the polymerase inhibitors affect the virus. And so that is shown here with the NS2, NS3, NS4B. This is where the cleavage of the polyprotein is blocked and thus blocking the replication of the virus. And it is a dramatic drop in the viral load in these patients. Within a couple of weeks, you will see in some of these patients almost 0 to no viral activity whatsoever. So this is essentially very revolutionary in the treatment of hepatitis C. But my talk today is not going to be on the actual treatments. And I'm not going to go through a cookbook process of telling you about the drugs. What I'm going to refer you to and what I refer students and residents and fellows to is this paper called hcvguidelines.org. And this is a website that gives you a cookbook guidance or manual guidance with the treatment of hepatitis C. It is updated continuously. In fact, when I gave the lecture to the sophomore medical students last year, I gave the lecture, told them the exam is in a week and a half. By the time the exam came around, the guidelines had changed and the website had been updated. So this is rapidly evolving. If you have read something on paper about hepatitis C, on printed paper, it's probably out of date when it comes to treatment. That's how rapid the changes are. You really need to make sure that what you're reading on the treatment of hepatitis C is the most up-to-date reference that you can find. So, if you look at patients who are now candidates for treatment for hepatitis C, we see that if you have no cirrhosis, that is, that there is no evidence of fibrosis or active inflammation on your liver biopsy, no normal appearing liver, then you are an excellent candidate for treatment for hepatitis C. But what we are also seeing now is that individuals who have compensated cirrhosis are also candidates for treatment for hepatitis C. So if you have no ascites, no encephalopathy or encephalopathy, you have not had a variceal bleed, or portal pulmonary syndrome or pulmonary syndrome, you're a candidate for treatment for hepatitis C. And since October and November of this year, the guidelines have also begun to include those individuals who have hepatitis C virus, cirrhosis, and hepatocellular carcinoma are now potentially candidates for treatment. And there also is a consideration for decompensated cirrhosis. Child's Pu B and C individuals may be considered for treatment in certain scenarios. If you are considering treatment, we do, however, have to hold that a liver transplant may need to be considered in these patients before treatment. So this is something that we are considering and looking at in all of our patients that we're treating for hepatitis C. So that's not the meat of the story that I want to tell you about. The meat of the story I want to tell you about is what else does hepatitis C cause? Well, it can cause metabolic effects, it can cause cardiac effects, it can cause nervous system or neurologic effects, hematologic and lymphatic effects, and there are some miscellaneous things that we will see that hepatitis C can do. Before I begin, the take-home point that I want for the students, if you get nothing else, that hepatitis C is a nasty little virus that can cause all kinds of problems. So that's the take-home point for y'all. So if we look at diabetes, if you look at the NHANES study, which is a survey of the nutritional and health of the nation, initially this study was looking at the cohort of patients between 1988 and 1994. Those who were over 40 years of age had an odds ratio of 3.77 of the development of diabetes if you have hepatitis C. And that's demonstrated here in the diagram shown here. Let's see if that goes down a little. There we go. Shown here on the diagram to my left, where individuals with hepatitis C were more likely to develop diabetes as compared to those who did not have hepatitis C. In addition, if you look at a population where you screened for hepatitis C, what you see is that those individuals who have hepatitis C have a higher cumulative incidence of the development of diabetes. If you look at it further with a case cohort study looking at a 9-year interval, comparing those who are considered low risk versus those who are high risk. And what I mean by high risk is anybody who is older with an elevated BMI over 35, an individual is 50 to 59 years of age with a BMI over 30, and an individual 55 to 59 years of age with a BMI of 25 to 29. If you look at the hazard or the potential of developing diabetes, you see that it is extremely high at about 11. So individuals who are high risk due to BMI and age and have hepatitis C are at a much higher risk of developing diabetes. There's also, from further looking at the NHAID study in a different cohort year time frame, or not cohort year, but a different time frame, what we see is an independent association of diabetes when we look further at the NHAID study for both diabetes, insulin resistance, and hypertension. So as you can see, that hepatitis C gives the indication that it can cause some metabolic effects to an individual. However, when we look at hepatitis C virus and the risk of diabetes and we compare it to controls in a meta-analysis, we definitely see the risk. So the next question you would ask is, does that apply also to patients who have hepatitis B virus? So B as in beta. And the answer is no. So individuals who have hepatitis C have a higher risk of diabetes as compared to those who have hepatitis B. So that again gives you an explanation, or gives you an idea that something is going differently on in the body when you have hepatitis C compared to other viruses that are present in the body. If we look at insulin resistance, we saw this slide just before, that the insulin resistance odds ratio is increased in individuals in our NHAID study. If we look at individuals who have hepatitis C virus, there is a greater risk of insulin resistance versus these hepatitis B virus patients, and that risk is about 35% in this study versus 5% for individuals who have hepatitis B virus. But they looked at it further and found that individuals who have a high viral load of hepatitis C have an increased risk of developing insulin resistance using the HOMA score. So these individuals who have high viral loads of hepatitis C are at greater risk of insulin resistance. And if you look at their potential for fibrosis using a Medivir, which is a staging system for fibrosis, you see that if you have more fibrosis, you're more likely to have insulin resistance. If you look at studies looking at the potential for insulin resistance using an experimental study using a hyperinsulinic clamp with tracers and indirect calorimetry, and this was a very small study. It only had about 20 patients in the study. If you had hepatitis C virus infected patients who had no metabolic syndrome versus controls, what you saw was that there was an increased production of peripheral and hepatic insulin resistance in these hepatitis C virus infected patients versus controls. And there was a threefold increase in that hepatic insulin resistance in these individuals versus controls. And if you look at the graph, this is demonstrating that effect in these individuals, with the individuals who are having hepatitis C found to have are in the black here in the graph. So additionally, in this paper, it was also interesting that I found that the cytokines in these individuals are also increased. And so you see that tumor necrosis factor is also increased in these individuals when you look at the production of, in these clamps, looking at glucose production. So these individuals have increased cytokines as a result of their virus in their body. If you look at insulin resistance, It is thought that it may be hepatic, but there is some evidence that instead of being hepatic, it may be peripheral. So there's a little bit of contradictory evidence here. In this study, looking at individuals who have hepatitis C in comparison for the liver fat, which is present in the liver, individuals who have hepatitis C are more likely to have fat deposition than they are in control patients. And we also see that that potentially occurs in muscle. There may also be some evidence that genotype 3 has more fat deposition than other genotypes for hepatitis C. We also see that fibrosis, as we saw earlier, and insulin resistance are associated. In a univariate analysis, we see that the HOMA score is higher in those individuals who have hepatitis C, and that the fibrosis score in these individuals is 2.0 versus 3.7 and is statistically significant. If you look at a multivariate analysis, this is where I was talking about insulin resistance may be increased in individuals with genotype 3, as shown here at the bottom of this table. The individual with a genotype 3 hepatitis C have an odds ratio of 11 for the development of insulin resistance. Furthermore, if we look at individuals and their HOMA score, what we see is that the HOMA score in individuals infected with hepatitis C versus controls, again, remains elevated regardless of which study we look at for these individuals. Now, how does this happen? So an individual who has hepatitis C, they get infected, they have lifestyle activity and genes that are involved in this interplay, which leads to steatosis, which leads to increased intrahepatic lipid oxidation, and the development of these cytokines like SOC S3 expression. Gluconeogenesis occurs and insulin signaling occurs, or decreased insulin signaling, which leads to increase in systemic lipid oxidation and increase in glucose production. And as a result, you get hepatic insulin resistance, and you also develop potentially muscle insulin resistance due to decrease in glucose oxidation and decreased glucose disposal. So this may be the mechanism by which individuals with hepatitis C develop insulin resistance. In addition, when we look at these, when challenged with insulin in an ex vivo situation, protein kinase B AKT is blunted in these hepatitis C virus infected cells, and that's a primary mechanism by which we see the metabolic effects of insulin. That glucose uptake may also be impaired by hepatitis C virus infection, and we also may see that there are pro-inflammatory cytokines like tumor necrosis factor and interleukin-6 that interfere with insulin signaling transduction pathways in these individuals in their hepatocytes. So overall, what you see is that hepatitis C causes an hepatic extrahepatic insulin resistance. And this became a problem when we were talking about treatment for individuals with hepatitis C, because we found in the era of pegylated interferon and ribavirin that if you had increased insulin resistance, that these individuals had a decreased chance of clearing the virus. So in the years past, that was a significant problem. But I'm here to tell you today that in the era of directly acting antivirals, we do not see this effect. So if you have insulin resistance, it is not as big a factor with the medications that we are now seeing come onto the market. So if we look at insulin resistance, it's correlated with poor outcomes. As we discussed, you get hepatic fibrosis, you get reduced SVR rates, and you also have the potential for development of hepatocellular carcinoma with the presence of diabetes mellitus. So your HOMA scores are also associated, and this insulin resistance, as I said, does not affect the directly acting antivirals. But if we look at hepatitis C virus and diabetes, just look a little bit more at this data, what we see is that if you look at patients in follow-up, individuals who develop hepatocellular carcinoma are more likely to be diabetic and to also have a higher hemoglobin A1C than those who are not diabetic or have a normal hemoglobin A1C. So this is an important concept, although not always practical to follow in a screening population, but it's just something to consider in your patients. From the standpoint of cardiovascular effects of hepatitis C, what we see is that individuals who present to us if you measure their lipid panels, what we see is that they have lower total cholesterol, lower LDL, and lower triglycerides. So if you see on this graph, those individuals who are normal lipids but have hepatitis C are shown here in the black bar. So individuals who have normal lipids are shown here in the hepatitis C versus those who are comparison to control group or have high elevated triglycerides. In addition, hepatitis C virus also causes a higher HDL level. There may be an association of hepatitis C with atherosclerotic disease, and we see that angiographically, coronary disease, which is defined by greater than 50% stenosis, is greater in those with hepatitis C virus than those among controls and other cardiac abnormalities. And this was found to be statistically significant. And the odds ratio of developing hepatitis C virus the odds ratio of hepatitis C being an independent predictor on a multivariate analysis for cardiovascular disease is 4.2. And if we look at individuals measuring the multivessel disease, collateral coronary vessel development, we see that individuals who have hepatitis C are more likely, in those who have seropositive hepatitis C, to have those findings than those who are hepatitis C virus seronegative. Additionally, we see that this effect of the hepatitis C virus in comparison to controls and those with hepatitis B virus is that you're more likely to have carotid thickening and also development of plaques. So again, the virus may be causing some effect outside the liver on the cardiovascular system that is independent of its effect on the liver. In individuals who have hepatitis C, they're more likely to have greater carotid plaques. And if you look at these individuals, you'll see that the 40% of controls will have carotid plaques versus 22% of those who do not have hepatitis C. And if you look at younger patients with hepatitis C, as shown in this graph here, you see that the individuals who have more advanced stage of fibrosis are more likely to have carotid plaque development. We do not see this effect in those who are in the older group, but we do see in younger patients that there is a greater development of carotid plaques. If we look at a retrospective study of individuals with hepatitis C and looking at blood donors, there may be an increase in cardiovascular mortality as shown in here in this graph from the American Journal of Epidemiology. So individuals who have hepatitis C positive, as shown in the black line here, are more likely to die of cardiovascular events. And in a prospective study, suggests that in an overall look at the circulatory system, that's peripheral vascular disease, carotid, cerebral, and coronary artery circulatory system, there is an increased chance of mortality in these individuals. So if we look here again at the dark bar shown here in the graph, these are individuals who have hepatitis C. They're more likely to have a circulatory system mortality versus those who are antibody seronegative. We also may see that these individuals have an increased risk of stroke risk. In this paper from PLOS 1, which was published in 2012, these individuals who have hepatitis C, when asked the question, is hepatitis C present, had a hazard ratio of 1.22, and that was statistically significant when you look at the confidence intervals. In addition, we may see that the viral load level may also be a predictor of an individual who has a risk for stroke. As you see in this graph, where the dark line here representing patients who have hepatitis C positivity are more likely to have a stroke. So now I've led you down the path that potentially these patients may have an increased risk in circulatory problems. But wait, this may not be the case because there are several negative studies in relation to hepatitis C virus. So this is going to be a little bit controversial with regard to the effect of cardiovascular risk in hepatitis C. So the negative studies, we'll go through those very quickly, is a large United Kingdom retrospective study in the incidence of acute myocardial infarction did not see a difference. There was a case control study of active duty U.S. military personnel over several years looking at serum samples found no MI association. There was a cross-sectional German study that found no association of hepatitis C virus or hepatitis B virus and atherosclerosis. And we also see that there was a small longitudinal study using ultrasound that showed no difference in the carotid or femoral arteries. So one of the things that we see with cardiovascular risk is that there are many confounders and that interfere with the analysis of data. So insulin resistance, we know, leads to hyperglycemia and endothelial dysfunction and inflammation, and that hepatitis C may induce a chronic inflammatory effect with systemic states, and that the development of liver necrosis and fibrosis leads to systemic effects, and that treatment of hepatitis C may lead to regression of perfusion defects and cardiovascular events in the interferon error, but we have no data on the directly acting antiviral therapies, and the data is somewhat mixed with regard to the risk of cardiovascular effects. So let's switch to the neurologic effects that we see with hepatitis C. And in these individuals, fatigue is very common in hepatitis C virus. And I will tell you, when I was training in residency and fellowship, we would often have patients talk about fatigue and how tired they were with their hepatitis C. Unfortunately, in the beginning, we just chalked it up to that they were just going to have to live with it, with hepatitis C, because the only therapy that we had was interferon and ribavirin at that time. And when you initiate therapy with interferon and ribavirin, one of the major side effects of interferon, up to 50% of patients, is flu-like symptoms and fatigue. So when an individual came in and talked about fatigue prior to interferon therapy, we had a little bit of difficulty in interacting with that patient because we knew that we were going to induce more fatigue with our treatments. So again, fatigue is seen to be very common in individuals with patients who have hepatitis C virus. And if you look at this graph, the dark line here represents those individuals who are controls. And in this graph, the lower the score indicates the more fatigue that an individual has. You see that individuals who have severe disease, shown with this dark dotted line and this light dotted line, these individuals report more fatigue. And up to 50% of patients will report fatigue. And we found that the findings that were associated with fatigue were being over age 50, being a lady, having cirrhosis, having depression, or the presence of the skin manifestation of purpura in a prospective study. And other studies have confirmed this, that over 50% of patients have developed fatigue in both a cohort and a retrospective study. We also see that the mental quality of life of patients is lower in individuals with hepatitis C. So it's a little hard to see here, but these individuals who are shown here in the slightly darker graph here, or in the bars, are individuals with hepatitis C virus, and you see that on several of these quality of life score factors that the individuals have a lower quality of life with hepatitis C. We also may see some cognitive impairment effects from hepatitis C. So if you are infected with hepatitis C, you will score, in a study, the patients scored lower on a computer-based cognitive assessment battery versus those who had previously cleared the virus. So if you have the presence of hepatitis C, you are more likely to have problems with your cognitive ability. We see that fibrosis is also associated with cognitive impairment, and patients, even without fibrosis, will still have the potential for these cognitive impairments. Researchers have looked at SPECT, dopamine, and serotonin transporter receptor binding, and looked at that as a measure of cognitive changes and found that they are lower in patients in hepatitis C virus. There is a compound called myoinositol that is increased in the brains of individuals with hepatitis C, and this has been shown to correspond to cognitive impairments that occur in individuals based on MR spectroscopy. If you look at psychosometric scores, and what I'm shown here in modifying this graph, that those individuals with this cross here are individuals who are found to see have statistically decreased psychosometric scores in individuals who had hepatitis C versus non-fatigue patients. So from a standpoint of verbal, performance, and global scores, individuals who have hepatitis C virus have lower functioning capacity. So if you look at individuals who have hepatitis C virus and you have HIV and you use methamphetamines, they also are shown to have lower cognitive ability. So the presence of hepatitis C in the presence, looking at a global deficit situation, and in this graph, those individuals who have hepatitis C, who have a higher score, have a greater global deficit. Those individuals with hepatitis C were more likely to have a global deficit. And if you add additional risk factors in these individuals, their global deficit increased. So if you have hepatitis C and you have other problems, then you're more likely to have a global deficit problem. And some researchers have been able to connect the presence of a higher viral load and the presence of co-infection with HIV to have memory problems. So in this graph, those individuals who have hepatitis C and a higher viral load are shown to have a potential for impairment in memory. Yes?
Were there any studies that showed that these individuals had a poorer cognitive ability prior to obtaining methamphetamine abuse, HIV?
No. Because there has not been a study that I have found where they looked at individuals high risk before infection. Oftentimes when you find patients with hepatitis C virus, they acquired the infection many years prior to the time that they present to their healthcare provider. Because remember, only a small percentage of patients with hepatitis C virus will actually present with an acute viral attack with jaundice or other symptoms of their hepatitis C virus. So, if we look at the mechanism by which individuals have neurologic effects on their from hepatitis C in the nervous system, we see that on proton magnetic resonance spectroscopy, we see that there are mild cognitive impairment and alteration in the cerebral metabolism. There is this idea that the choline-creatinine ratio and the myo-inositol level is elevated in individuals with cognitive impairment, and we see that that is in greater abundance in those individuals with hepatitis C. And again, we look at the idea of hepatitis C virus as an inflammatory virus causing inflammation, and it's thought that maybe the hep C virus is entering the brain through the central nervous system and causing neuroinflammation. And if we look at that from a graphical or cartoon state, we see that the blood-brain barrier is shown here on this graph. And in these individuals, you see that there are astrocytes and that there are macrophages that occur here where there's infection by the virus and these virus-infected particles, and it leads to the production of these cytokines, which then causes microglial activation and subsequently to neuronal dysfunction in the brain. So there may be this idea that hepatitis C virus can invade the brain and thus cause injury. The greatest association of hepatitis C virus with an extrahepatic effect is actually seen in the idea of the hematopoietic system and development of mixed cryoglobulinemia and lymphomas. So if we look at individuals who have mixed cryoglobulinemia, what you see is that 91% of these patients with mixed cryoglobulinemia have hepatitis C virus. And we knew that individuals with cryoglobulinemia before we had identified hepatitis C virus were associated with non-A, non-B hepatitis. If you have cryoglobulins, there's a 5% chance that you will develop symptoms in these patients. And this can range from very mild symptoms, which are fatigue and purpura, arthralgias, and this can progress to glomerulonephritis or widespread vasculitis. In 90% of these patients, they report fatigue. And the skin manifestations can be palpopurpural to these large ulcers on the cutaneous skin. You may also see arthralgia, Sika syndrome, and neuropathy may also be present. What we see in the lymphocytes is that there is a clonal expansion of the B cells in response to these viral antigens, and this can lead to production of rheumatoid factor-containing immune complexes. We also see that there is complement C1q-mediated vasculitis in the small vessels that can develop. And we also see that the hepatitis C virus may stimulate the B cell proliferation through a direct interaction of the hepatitis C virus through the E2 glycoprotein with the CD81 receptor on the surface of the B cell, and this may directly bind to and activate these specific receptors for hepatitis C on the B cell. And so if we look at this in a cartoon perspective, what we see is that at the top of the screen, the marginal B cells, they bind these hepatitis C virus particles and core protein then that causes a clonal expansion from the B cell that then leads to genetic alterations and may lead to the development of non-Hodgkin's lymphoma. You may also, in addition, you may see these cold precipitable immune complexes, or the cryoglobulins, and development of IgMs with rheumatoid factor affinity. And this can lead to vascular endothelial activation, and that thus leads to the leukocytoclastic vasculitis that we see in patients. For those who are more interested in the mechanism by which hepatitis C virus causes cryoglobulinemia and other effects, I would refer you to this article from the New England Journal in 2013. I'm not going to go through the details of this, but it goes into more detail into how the pathomechanistic activity occurs with hepatitis C virus. So moving on to hepatitis C virus and non-Hodgkin's lymphoma, we see that these B cells with mixed cryoglobulins show a restricted Ig heavy chain use, and we see that VH169 and VK320 are highly overrepresentative. And so if you see this clonal population in somebody with hepatitis C virus, it puts them at risk for a non-Hodgkin's lymphoma. And this non-Hodgkin's lymphoma is really considered a low-grade lymphoma with a rate of about 6.6 per 1,000 person years. However, it takes more than just the hepatitis C virus to drive this person to the lymphoma. There has to be what is called a second event, or the second event theory has to occur for these individuals to develop non-Hodgkin's lymphoma. This non-Hodgkin lymphoma is a result of the expansion of particular memory B cells. And it's thought that the viral antigens drive that process. And even though you may lose, there is some point that there's a loss of the protective mechanisms, and that leads to that low-grade non-Hodgkin lymphoma. However, in a small minority of patients, they may also develop a high-grade lymphoma associated with hepatitis C, which uses an alternate mechanism by which you develop the non-Hodgkin's lymphoma. Now, when we look at the association of hepatitis C and the mixed cryoglobulins and non-Hodgkin's lymphoma, the greatest evidence associated with the association here is after treatment, that we see a regression of things like the mixed cryoglobulins. And this has been seen most abundantly in the pegylated interferon and ribavirin era than it has been with any other era, because we have the most data for that. We have almost 25 years of data associated with interferon use and hepatitis C. Occasionally, though, even if you treat somebody for the mixed cryoglobulins and hepatitis C, these individuals persist with their mixed cryoglobulins. And what that suggests that at some point in the cell cycle, that the antigen no longer is necessary for the development of these cryoglobulins. So even though you cure the patient, theoretically, of the hepatitis C, so you develop an SVR, they may still continue mixed cryoglobulins. We've also used other therapies for treatment of the mixed cryoglobulins by depleting B cells. And this is where rituximab, the anti-CD20 B cell depleting agent, has been used for treatment of patients for cryoglobulins and hepatitis C. And I actually have one patient who has just been approved for the directly acting antiviral therapy and has been on rituximab for quite a while, and we're hoping that we can now treat her with therapy and reduce the use of the rituximab and hopefully eliminate the use of rituximab in her case. If we look at the hepatitis C virus-associated non-Hodgkin's lymphoma, we see that low-grade non-Hodgkin's lymphoma may actually be able to be treated just with antiviral therapy. So there's some individuals who treating the virus leads to regression in the non-Hodgkin's lymphoma, and we hope that these directly acting antivirals may be beneficial for these individuals with low-grade non-Hodgkin's lymphoma. For those who have the high-grade non-Hodgkin's lymphoma, these individuals' primary treatment for their lymphoma is required, and then consideration for the treatment for the hepatitis C virus. So if you have high-grade lymphoma, they are not candidates for treatment at this time, but after they are actively treated for their lymphoma. And now I'm going to move on to a different discussion of some miscellaneous topics with regard to hepatitis C and what it can affect. So there are also some ophthalmologic effects, and one of which is called a Murren's-type peripheral ulcerative keratitis. This is an ulcer that can be seen on the eye. In discussing with my ophthalmologist when I was preparing this talk, she indicated to me that she had only seen maybe one Murren's ulcer in her career, and when you do develop them, they're very resistant to treatment and can destroy the cornea very easily in these patients. And we know that there is some improvement in these individuals if you treat them with interferon. So again, we're hoping that new therapies will be able to treat these patients with hepatitis C and lead to improvement in symptoms. And if you look at a Murren's ulcer, this is an example of Murren's ulcer, which I found on the internet from the Online Journal of Ophthalmology. And you can see that it is a nasty-looking eye manifestation that it's seen in some of these patients. There is also a causal link in isolated claims of Behçet's disease in individuals who have hepatitis C, but this has never been fully validated. And if we look at other cutaneous manifestations that are associated with hepatitis C, we can also see that lichen planus may also be seen in these individuals. Although not seen in cutaneous lichen planus, in oral lichen planus, there has been some studies that have shown the replication of the hepatitis C virus, making the association with lichen planus and hepatitis C virus. And in cutaneous conditions, it's less concrete for the association with hepatitis C. Some individuals report pruritus associated with hepatitis C virus, and this is a controversial association that is seen. And there was some discussion in years past of individuals who have pruritus and testing those individuals for hepatitis C virus in order to screen for hepatitis C virus, but that recommendation has never been made now to do screening for hepatitis C virus if an individual comes in with pruritus. Another condition that can be seen in these individuals is porphyria cutanea tarda, and 50% of patients who develop porphyria cutanea tarda have hepatitis C. And there are some environmental and genetic factors that occur in these individuals that triggers them to develop this condition. In all of these patients, there is some degree of iron overload or oxidative stress that has occurred that results in the development of the PCT. Previously, we treated PCT with interferon and ribavirin and did not see great results. And then some people have treated them with phlebotomy in the past. So again, this is another area where we're hoping that the DAAs are able to help with the treatment of these patients. There are some additional miscellaneous disorders associated with hepatitis C that we see, including rheumatoid arthritis, which has an increased risk in individuals with hepatitis C virus. So if you have hepatitis C virus, there's something about the genetics of the virus that leads to that inflammatory state that puts people at risk for the development of rheumatoid arthritis. We have also seen an association with pulmonary fibrosis, and this fibrosis is increased in individuals based on age, smoking, and the development of cirrhosis, in addition to the presence of hepatitis C virus. As we also know, in the interferon ribavirin era, that individuals also had to be screened for thyroid disorders before we treated them for hepatitis C virus, because the virus can cause a hypofunctioning thyroid or a hyperthyroid activity. In addition, when we used interferon, we could also cause hypothyroidism or hyperthyroidism in these individuals. So there is some autoimmune effect on the thyroid associated with hepatitis C virus. And finally, when we look at other hematologic factors, we see there is some association with autoimmune hemolytic anemia and autoimmune thrombocytopenic purpura. So the reason that I went through all of these items and discussion of the various effects of hepatitis C virus is that many of these things that we saw, such as insulin resistance, uncontrolled diabetes, individuals who had significant thyroid problems, or who had cardiovascular disease with increase in atherosclerosis, were not candidates for treatment for hepatitis C virus. So the reason I'm presenting this to you is because now these are all individuals who may be candidates for therapy for hepatitis C virus. These are now the benefits of eradication in these people with hepatitis C virus. So what we see is that there is a reduced chance of steatosis. There's a decreased chance of moving to malignant lymphoma. It reduces your chance of diabetes and insulin resistance, and we see that after treatment for hepatitis C that these individuals have decreased fatty liver and insulin resistance years later when we look at their livers. It may cause an improvement in cognitive performance. You see a reduction in fatigue. I can absolutely tell you that every one of my patients who I treat with directly acting antiviral therapies following the completion of their treatment all report that their fatigue is improved. In fact, they report that their fatigue is improved 48 to 72 hours after the initiation of their therapy for hepatitis C virus. So there is a substantial improvement in fatigue that is seen with treatment. There's an improvement potentially in myocardial and perfusion defects, reduced incidence of stroke. We see that there are decrease in cardiovascular outcomes and renal outcomes in individuals who have diabetes and hepatitis C virus. There may be complete resolution of myoglobinemia related complications in these patients. And there's also, in some cases, regression or complete remission of lymphomas that is associated with hepatitis C. And with the treatment, we also see that there are reduced mortality and decreased progression to fibrosis and cirrhosis in individuals with hepatitis C. So what is the future? Well, the future is the directly acting antiviral therapies. And they are the recommended treatment for hepatitis C virus. As I've just told you before, the story of pegylated interferon and ribavirin is what we know because that's what we've used in the last 20 years. But those are no longer recommended therapies for patients with hepatitis C. There are minimal side effects with these newer therapies. The only real side effects that we really see are fatigue and headaches. The fatigue is fairly mild and resolves upon completion of treatment with a very small amount of time for treatment. For those of you who are students in the room, pegylated interferon and ribavirin was a treatment for 48 weeks. So what that means is that once a week you got a shot of interferon. The interferon induced significant fatigue, muscle pain, and flu-like symptoms every week. As one patient told me, it felt like I developed rigor mortis once a week. So now we have therapies that do not induce these significant side effects. We still have cost containment issues that exist for treatment. The average price for treatment for therapy now is about $84,000 for a treatment course. Insurance is paying for most of these patients for treatment, but there are limitations of which the insurance companies are paying for these drugs. In the case of Medicaid, it is requiring that an individual have already developed fibrosis before they can be treated. Other insurance companies are limiting the number of patients that they allow through the process at a time, and they have other criteria that they use for treatment for hepatitis C. So cost is still a problem for treatment. On Thursday, as I told you, the FDA will be looking at the new drug, and we do not know the cost of that drug. But we may not even have to worry about genotyping the patient to figure out which treatment to give them. It may be an all-comers if you have hepatitis C virus for consideration of treatment. So the reason that I brought this talk to you is because the extrahepatic manifestations of hepatitis C are further evidence of the need to treat for hepatitis C virus. We have now reached a point, I believe, that if an individual has hepatitis C virus, we have to rule them out. Correction. We have to rule them out for treatment rather than rule them in for treatment. In the years past, we used to rule people, say, yes, you cleared this, check, 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 check. There were about 20 or 25 different things we had to check before we considered from treatment. Now what we're doing is looking at a patient and going, well, I think you're a candidate for treatment unless I find something. So now all patients should be considered for treatment, in my opinion, except for those who are considered for treatment for liver transplant or other rare situations. And the other thing is that these extrahepatic manifestations were really contraindications for the treatment of hepatitis C, and now they are becoming indications for treatment for hepatitis C. And with that, I will conclude my comments. Thank you. Any questions? Yes.
A common patient or a common common patient we see here is someone who's got Hep C and also abuses alcohol.
Yes.
What happens? How is that factored into consideration?
So in the era of interferon ribavirin, let's start historically there, there was a problem with the alcohol usage potentially causing an interference with the clearance of the virus. The latest data based on HCV guidelines is that alcohol is much less of a factor with regard to effect of the actual directly acting antivirals and the potential of achieving SVR. However, you still have to play in the factor that somebody who's drinking a fifth of rum or vodka per day is an increased risk of development of cirrhosis. So you have to weigh that effect of how much alcohol are they drinking and the potential of developing alcohol-related cirrhosis versus just a small amount of alcohol. So we still tell patients to stop drinking alcohol, but we may be considering in the near future begin to treat some of those who are actively using alcohol.
Do the insurance companies factor that in?
Have not seen that effect yet. Most of the patients that we see who are very heavy alcohol abusers don't have insurance right now. That may change in July. Any other questions? Okay, thank you.